Good morning, everyone. Let me present my 15 months progress on my PhD topic, which title is Investigating Different Etiologic Factors of Preterm Birth. I am Eszter Hoffmann, and I work as a resident doctor in the Department of Obstetrics and Gynecology in Semmelweis University, and my vision is to contribute to the prevention of preterm births, and my mission is improving the protocol for the treatment and prevention of vaginal infection during pregnancy. I have 3 ongoing projects. And now let me talk about my first project, which title is Routine Screening of Vaginal Flora During Pregnancy Reduces the Odds of Preterm Births. The background of this topic is that the incidence of preterm births is between 5 and 18% worldwide, and in Hungary we spent almost 8 billion forints for the first 6 months hospital care of the neonates. On the left side, you can see a figure where we can see that as the number of the weeks of gestation decreases, the risk and the chance of the complications and mortality gets higher and higher. There are different etiologic factors behind preterm births, and the most important ones are infection and inflammation, and there is no protocol for screening of vaginal infection during pregnancy care. And our aim is to see if routine screening of vaginal infection could prevent preterm births. Our clinical question was that can regular screening of vaginal flora during pregnancy decreases the rate of preterm births and premature rupture of membranes. The population was pregnant women, the intervention was screening of vaginal flora, the comparison was no screening, and the outcomes were preterm births, low birth weight, premature rupture of membranes, and the risk factors of preterm births. And our hypothesis was that regular screening of vaginal flora can reduce the rate of preterm births. We did the systematic search in October in 2021, and we found 13 eligible articles for the meta-analyses. And now let me talk about our first outcome, which was preterm delivery before 37 weeks. And here we can see we got significant results, and here we can see that screening compared to no screening can significantly reduce the odds of preterm delivery by 29%. We did a subgroup analysis by study type, and here we can see that unfortunately we didn't get significant results, but this data still suggests that screening can have beneficial effects in the prevention of preterm births. We have another outcome for preterm delivery before 32 weeks. And here we can see that screening compared to no screening can significantly reduces the odds of preterm delivery before the 32nd week by 49%. We have an outcome for the low birth weight, and here we can see that we can reduce the odds of preterm deliveries with low birth weight by 36%. And we did a subgroup analysis by study type in this case as well, and here we can see that we got significant results, and the odds can be reduced by 29%. And our most relevant and most important outcome is birth weight under 1 kilogram. These neonates are usually born before the 28th week of the pregnancy, and that's why it's very important to avoid this scenario, because they have the highest risk for mortality and complications. And here we can see that screening compared to no screening can reduce the odds of preterm delivery with birth weight under 1 kilogram by 67%. These were our outcomes, and I was talking about the 4 most relevant ones. And as a summary, I would like to say the strengths of our study, which is the high number of patients, the different type of screening methods that were examined, and the screening methods that were examined were easily executable. The limitations of our study were the low number of RCTs and the different type of treatment and pregnancy care protocols in each country. As a conclusion, we can say that routine screening of vaginal flora can reduce the odds of preterm births, and we found the strongest significance in studies where screening was performed by healthcare specialists. And an implication for practice, we can say that routine screening of vaginal flora is recommended during the pregnancy care and strongly recommended in high-risk population. And an implication for research is that further RCTs are needed in case of pH screening and the gram stain as well, and the screening methods should be compared to each other. And we submitted our manuscript, and we sent it back after the revision, and now we are waiting for the decision of the editor. And now let me talk about my second project, which title is Investigating the Efficacy of Treatment of Abnormal Vaginal Flora During Pregnancy to Reduce the Rate of Preterm Births and Premature Rupture of Membranes. The background of this topic is that a common cause of preterm birth is infection, and there is no guideline for managing vaginal infection during the pregnancy care. And if we talk about the treatment, we can use oral or local treatment. We can use antibiotics like metronidazole, clindamycin, or clotrimazole. We can use the lactic acid, probiotics, or we can say that we don't treat at all because the infection is asymptomatic. Our aim is to see if the treatment of abnormal vaginal flora could prevent preterm birth. The clinical question was that can treatment of abnormal vaginal flora during pregnancy decrease the rate of preterm birth and premature rupture of membranes, and which is the best treatment? The population is pregnant women, intervention is the treatment, any kind of treatment, comparison is no treatment, and the outcomes are preterm birth, low birth weight, premature rupture of membranes, and the risk factors of preterm birth. And our hypothesis is that treatment of abnormal vaginal flora can reduce the rate of preterm birth. We did a systematic search in the 21st of October, and we repeated it in the summer this year, and we found 41 eligible articles for the meta-analysis, and we finished the data extraction and started the risk of bias assessment. And we have a third project, and let me talk about it in a nutshell. Its title is Genetic Variation Associated with Preterm Birth. And the background of this topic is that the etiology of preterm birth is variable, and both maternal and fetal genomes likely affect susceptibility. Different genes can be associated with preterm birth, but more examination is needed according to the literature. And we are planning the examination of placentas that were collected from pregnancies with intrauterine growth retardation, preterm birth, and from a control group. And we are planning the examination of inflammation and preterm birth associated genes like MBL2 and DFB1. And our aim is to identify fetal genetic variants that predispose infants to preterm birth. And as a summary, I would like to show the 3 ongoing projects. And to close my presentation, I would like to share a quote from my favorite basketball player who said, "Everything negative, pressure or challenges is all an opportunity for me to rise." Thank you for your attention.
Congratulations, Eszter. Actually, the PRISMA checklist is also asking for not only implication for research and practice, but also implication for policymakers. So that's the third point. I don't know why, but we are not including it in our papers. Of course, also because it's very hard to formulate ideas for policymakers, what to do with your results. However, I'm just wondering that with this kind of clear results for your first meta-analysis, how can we convince policymakers to implement something, or is it actually already happening, or are we influencing? How can we influence on a much larger scale decision on this topic?
Thank you for your question. It's a good question. I don't know exactly how should we convince them, but probably if we have a publication, then it can prove that it's serious. These are serious results. And
actually, I have to say that the publication is a very good first step. I have to say, for example, Brigit's first meta-analysis was recently cited by the SG, the European Gastroendoscopic Society, in a guideline that they were using gives meta-analysis also as a reference. So of course this can be a very good first step. As I was saying, it's very hard to formulate, how to convince them. Of course you also have to think with this kind of mindset that not only from the patient side or from the physician side, but also with that kind of thinking.
Just a comment, in plenty of times during your presentation you mentioned that you are unhappy not having significant, mathematically significant data. I have two comments about it. First of all, having significant or non-significant data, both of them could be highly important. So never be sad just because something is not significant. Secondly, mathematical significance, plenty of times not matching with the clinical significance. So in that case, it might be better to quote that it's clinically highly significant, and most probably due to the low N number, it hasn't reached the mathematical significance yet. But you are always upset when you are saying in every presentation, so I couldn't resist not to mention it.
Thank you.
Thank you.